Okay, welcome everybody. Thank you for joining us today at our late edition of our monthly webinars. We're trying out this new time and hoping that we can catch either the same group or more people and see what's more convenient. Give people two options. So you may see these webinars alternate between noon and 5 o'clock. And then later this year, we're going to send out a survey and just kind of see where everybody would like us to land for next year. So welcome. Thank you for joining us this evening. We're very excited to have Tiffany Romershausen and Mysti Motz here today with us to talk about advanced health practitioners and providers and nursing in neuroendocrine specifically. So I'll let them both introduce themselves and we'll go from there.
Mysti, you want to go first? You want me to go first?
So my name is Mysti Motz, and I currently work at the University of Miami Sylvester Comprehensive Cancer Center. I have been a nurse for 10 years. Almost all of them have been in oncology, but the last 3.5 specifically have been in neuroendocrine. And it has been a very fun journey, but a very interesting journey as well, as we'll get into today. I'm happy to be here with you all.
We're happy to have you.
Good evening, guys. So my name is Tiffany Romershausen. Like Tamia said, I'm a nurse practitioner at Moffitt Cancer Center, specifically in GI, but even subspecialize in neuroendocrine tumors predominantly. And I've been working in some oncologic fashion for about 10 years, but neuroendocrine tumors within the past, like a little over a year.
They're both being very modest and oversimplifying their role and their impact on all of this over the years. So, Tiff, we can start with you. I know we met about almost 9 years ago now when we were both doing research. So, can you talk a little bit about your kind of transition into the APP world and what led you to this point?
Sure. So, yep, we did meet in phase 1 clinical trials way back when. It seems just like yesterday, but it was a while. And so I did develop a love and a passion for research, but I still felt like I wasn't as involved with patients as I would like. So I ended up working for a breast oncologist surgeon in private practice for a while, and then ended up going back to school to obtain my RN license because, I just love school and wanted to be more involved. I couldn't decide if I wanted to do the RN track or the physician assistant track, but I just love the patient care aspect of RN. So I did that for a while at the VA in like a step down surgery unit. And that wasn't enough for me because I knew that going back to serving alongside cancer patients was really my passion as well as research. So I took a little brief detour and ended up coming back to Moffitt as a clinical research nurse, and then ended up pursuing my master's in nursing. And I just knew I had to be some way, shape, or form involved in medical oncology and cancer. So it's kind of my story.
I love that. What do you feel is different? I mean, you've seen so many different cancers at this point. How do you feel neuroendocrine is different than the rest? And what special things do you feel like you have to adapt with this patient population that you haven't before?
I think it's so different, right? So for me specifically, I worked with that breast cancer surgeon for over 2 years. And, if we're doing just a direct comparison between breast cancer and neuroendocrine tumors, it's very different, right? So breast cancer primary obviously originates in the breast. With neuroendocrine tumors, however, the primary site can be, various places. It could start in the pancreas, it could start in the lung, it can start in the small bowel. And so that, keeps you on your toes, if you will, with neuroendocrine tumors. A good thing is with this disease that, a lot can be treated, and managed as a chronic condition, which is, amazing because with breast cancer, unfortunately, that is not always the case. And I feel like even with, breast cancer and neuroendocrine, surveillance, the importance of surveillance is, so important. And, having a routine follow-up with your medical oncologist is so important. But I even feel like it is more so with neuroendocrine tumors because I've seen that patients can kind of get comfortable. They're like, oh, my disease has been stable for years. I don't need to see my medical oncologist. I don't need to follow up. And then unfortunately, they come back to us after, a few years and there's been significant interval change. And, if they would have been maintained on a surveillance plan and schedule, whether it be every 6 months or, whatever your medical oncologist has you on, we could have expeditiously addressed interval changes and managed their care a bit more effectively.
Mm-hmm. Mm-hmm. Absolutely. Mysti, you are a nurse, but I feel like your role is a lot more different than just a clinic nurse, right? So, for most patients, you have your nurse who is your provider's, right hand in the clinic, and maybe dealing with your medications and things like that. But Mysti, your role is a little bit different than that. Can you describe a little bit of what you do exactly and then how you came to it? As exact as you can, because you do a lot.
I'll start with how I came to it. So I worked very similar in a few different areas of oncology. I actually started oncology in the bone marrow transplant area and then dealing with the hospice side inpatient. And so that was a very interesting segue into oncology from nursing school. From there, I ended up doing about 4 years in pediatric oncology, seeing the gamut of all different types of primary locations and disease tracks and the way we treat. So that was really good education. I left the university I was at before, went into public health for a small bit, and then I decided I didn't love it as much as I loved oncology. There's something about being able to walk through these doors every day and help these patients find what they need, getting back on track. So that's where I came to meet Dr. Shahan, who I work with. And he was still in the University of Kentucky at that point, and I was his clinic nurse. And that is the role that led me to fall in love with neuroendocrine, as much as you can, a cancer.
Why it's like that?
That is.
It's not usually like that.
So when I was working with him, I learned a lot about the disease. I learned and understood more about the transition between treatments, how patients get to us, that there are patients everywhere, but not everyone has a net specialist near them. So with that, I learned kind of the ins and outs of helping him manage a practice. So as we moved to Miami, he's building a new practice, and that's something that's not been at the University of Miami before. So here, I currently am in the process of helping him build the program. So that means that I'm involved in a little bit of helping the research trials get off the ground, understanding the ins and outs of working with different departments to make sure we have access to all the treatments we want to be able to offer. I also deal with all the administrative side of making sure the office has what it needs, hiring the teams that we need, but I also still help with clinic operations. So I still get the joy of being able to help my patients, answering the calls to make sure they're getting the help they need. But it's a lot more kind of hands in all the pots, making sure all the pieces are connected where they need to be.
Mm-hmm. Oh, absolutely. What do you feel is something that you're discussing almost weekly with patients, or a question that comes up very often, and both of you can kind of take that, and how you would guide a patient that you haven't seen yet before on that question? I know that's really random.
Probably the most often would be when they're coming in as a new patient. Is he going to be able to give me all the answers to what's going on because they've been seeing a non-specialist? And
Mhm.
that's the hardest one, because he can help you find out what's been going on, help guide the local person that is doing your treatment, but it doesn't always mean we're going to give you all the answers you're looking for. Neuroendocrine is so hard because a lot of people wait a long time for a diagnosis. So you finally get one, but cancer is not always a good answer, but you have an answer. Even then, when things change, there's not a clear-cut exact path like a lot of other cancers. We know what to do and what works. Neuroendocrine, we're still piecing together a lot of these things. So that's probably the most common is, what answers are you going to get me answers? I've been waiting so long, and it's a hard one.
Mhm.
So we have to be very patient and very compassionate, because if I was in their shoes, I'd want to know as well. But sometimes just being able to have the conversation with someone that knows and has been doing this for a long time and can help guide the people that are actually treating you at home is the key.
Yeah, absolutely. I think that you hit that about the specialist. Seeing a specialist is important. It doesn't mean though that you can't keep and that there is no value in your community oncologist, your local oncologist. It's a team. It's just somebody's kind of, running the game plan, if you will, and then somebody's executing. And your local oncologist that's seeing you more often is probably going to pick up on things that we may not see at a cancer center like Sylvester or Moffitt, where we're seeing you in between for scans and things like that. So just knowing how to navigate, I think those two providers and understanding that they're not separate from each other in that way. They are working together, even if they're at separate institutions. It just looks a little bit different. What about you two?
I'd say there's at least probably, I think, three common themes, right? At least with established patients, because that's what I, commonly see. I would say, when's the next time we're going to get scans, right? When are we going to start seeing, my response from treatment? And so it's really important to realize that we would not recommend, restaging, a month after you start therapy, unless there's, interval change that's, leading us to believe that there might have been some progression, right? Then we would scan you sooner. But like, for example, with certain therapies, we'd like to do 3 cycles, and that may look like 3 months, right, of therapy before we get another restaging scan. And what restaging scan means is, we look at your baseline scan before you started therapy, and then you get treatment, right, for those 3-ish months. And then we get a new scan to assess the treatment response. So I do feel like that's a common question. And, I'd have the same one, right? If I was on therapy, I'd, want to know if the treatment's working, but unfortunately we can't do it too soon, because we might not get the response that we want. So that's one question. Second question would be, what's next? What's my next line of treatment if this doesn't work? And that's really an important question to, have with your provider. That's something I'm always thinking about on the forefront. And caveat to that is also clinical trials. Is there, a clinical trial that suits my, case? So that would be number 2. And then number 3 is a hot topic. I probably hear it about 10 times a week, is histotrypsy. And that is something we do not pursue currently at Moffitt. And histotrypsy, it's very important to know that just focuses on the liver, right? So it's not a systemic therapy. So if you have neuroendocrine in different parts of your body, it's only going to address, hopefully address, right? That's the goal, those spots in the liver. So that's definitely a hot topic at the moment.
Yes.
Are you hearing that a lot too, Mysti? Yeah.
Yes, I think that's the most common theme among new patients is we offer it currently. What are our thoughts on it? And then even probably twice a week we get it with our patients that we were seeing on a regular basis. If we decided to bring it yet, if we've looked more into it, if we've changed our opinion on it. So
yeah, I think that's one, do you offer it, and 2, what's your opinion? And it's hard to give an opinion on something that hasn't been formally studied specifically in this patient population. It's not something, these devices get approved in a completely different route. I don't think patients realize that the process for device clinical trials is different than treatments. And so, not to say that it's a bad thing at all. It's just not as evidence-based as systemic treatment once it is approved is. So while it is catchy, you're going to see, articles and things like that. We still have other modalities that do pretty much the same thing that are established that we are using, like ablations, and pretty much everywhere will offer that, like Moffitt and Sylvester and things like that. I think the scan question, I agree. I used to get that a lot coordinating, where when patients are on trials, they're scanned at a frequency that's preset. And then when they're off a trial, the provider's kind of leading that determination. And it's not set in stone like it is in a trial. So how do you guys address that with patients?
So I think sorry, go ahead, Mysti.
No, go ahead.
I was going to say, so I see a lot, I have the pleasure of seeing a lot of clinical trial patients. And with my background in phase 1 clinical trials, I feel like that really helps. because what happens is with clinical trials, there is a very specific calendar and specifications that have to be maintained, right, for the integrity of the study and what they're trying to deduce or gather, right? So we, unless we think that it's necessary to get a sooner scan or a scan off trial, we of course as the provider can always do that. But otherwise, the trial is like what Tamia said, they really do dictate when we get the scan. It doesn't necessarily matter. For example, I had a patient who, was a little delayed starting the actual clinical trial medication, but that didn't, her scans were not adjusted, right? Because there was a delay in starting the medication. That was just the way, the trial worked, the trial schematics worked. And there was nothing, that myself or my attending, doctor could do about that. Now with, standard of care, we dictate when, you get your restaging scans. And like I said, for example, with everolimus, we'd wait, 3 months of therapy, and then we get a new scan. And very similar with, capecitabine and temozolomide, we'd also wait about, 3-ish months of complete therapy before getting, restaging scans.
And obviously it's important to note that every patient's going to be different, right? So whatever that pace of growth was to start with, I'm sure is going to differ on how frequently or infrequently you scan a patient. You touched a little bit on the dynamic between the APPs, the nurses, and the providers. Can you guys give a little bit of a behind the scenes for patients? Because I think, questions that I get sometimes are, what's the difference between my PA or my nurse practitioner and my doctor? Why are there all these people that are on my team? Is one more or less important than the other, and things like that? So how would you guys describe that? Maybe we can start with you, Mysti.
I would say that you need all of these pieces on your team, because it's kind of like having all the tools in a toolbox. You don't want to necessarily try to put a bed together without the screwdriver, but you also need the hammer. You're going to want all of these pieces. So the APP is a resource for the provider, the nurse, and for you. So they can help with the in-between symptom management. They can send you prescriptions for some things to help cover the in-between moments. They also can answer a majority of your questions. They have that direct line with the doctor. So they work with him or her in tandem to make sure that you're getting the care that you need, your treatments are on time, the scans are working the way they need to. The nurse works kind of in tandem with both of those in a different manner. She's helping answer the questions. She's a direct line of, I'm not feeling well, I wanted to get more Zofran. The nurse can usually handle that without involving the other two. So that alleviates them to make sure that they're dealing with the more pressing issues for the patients that are sicker, or the newer patients that are coming in that need a lot more overhaul or getting admitted to a hospital. So there's the dynamic of answering questions for all three. Your doctor is going to be your in-depth one for your treatments, but the nurses can usually handle, can I get my provider at home a copy of the scan? We can get those type of things handled. The APP can manage the in-betweens as well if the nurse is not able to handle, the doctor is busy. So it's very much like a flow. So there are levels to the ability and what their license covers, but there's a flow between the work between all of them. But it's an interconnectivity where you want all of the tools in the toolbox.
I like that. Tiff, do you have anything to add, or your description of that?
I completely agree with Mysti. I think you did a great overview. Just to add to that, nurse practitioners and physician assistants, our licenses are dictated by the state, so it will vary from state to state. In the state of Florida, it's pretty similar. There are some, differences between us both, but we can, prescribe medication, we can treat, like Mysti was saying, we can, manage those and mitigate those side effects and symptoms that you're having, answer questions and address those. The way I like to educate patients and counsel them the first time that I'm meeting them is, of course, I introduce myself and tell them I'm a nurse practitioner, and I work alongside my medical oncologist, my, doctor. And it's like having two providers for one, right? So who wouldn't want two providers, right? While they're undergoing cancer treatment or any treatment, all right? I want two providers.
Mhm.
So long story short, I tell them, and it is very true that I work very closely with my attending. If I have any, questions that I am, the slightest unsureness, I, always go and ask her for her counsel. But yeah, we work very, very closely together. They're very involved in their care. It is not just because you see a nurse practitioner, physician assistant does not mean, you're never going to see your doctor again. I would recommend at least every other time or every like few times that circle back with the medical oncologist and at least try to, get a in-person, face-to-face time with them as well.
That's a good point. So you mentioned that you work closely. That means that even if you're just seeing the nurse practitioner that day or the PA, they are talking to the physician that day. They know the physician is always involved and always aware of what was discussed and what is the next steps or if anything has changed. So working closely means that they are always in step. They just may not have been the one that physically saw you because they were seeing other patients that day.
Yeah, that's great.
Yeah. What is something that you wish you knew before you got into this?
One thing?
The first thing that comes to mind.
How resilient patients can be.
Mm-hmm.
We all know that we can do a lot of things when life hands us horrible situations, but there are so many things that I've learned from them. I always appreciate a patient that is very grateful for a situation that we've handled and we've taught them things and we've provided feedback and guided them and been able to get them what they needed. But we learned, I would say, at least twice as much, if not more, from the patients about how to handle things, about when we messed up and how to be better at our jobs. So that was something that I wish I would have known in the beginning, because I think I would have taken better notes my first few years and I would have been better sooner.
No,
I think for me, I would have liked to know that neuroendocrine tumor patients are for the most part, very educated about their disease. So they keep me on their toes. They keep me on my toes, and I keep them on theirs too. But in the beginning, I'm like, man, these patients are so well educated. And it's not like a WebMD educated. It's like, oh, I read the NETTER-3 trial. Oh, I was reading this, that, and the other thing. So that would have been, a really nice heads up. But I mean, I'm very grateful for that because, like Mysti said, like I've learned a lot from patients, and I really do hope that they've, learned from me as well.
No, I think that's a really good point. I think that's part of the reason that all of us that love this disease love it. I think that's a huge factor, to be honest, is the fact that patients are so involved in it. It feels like we're all collectively working on everything at the same time together. They're the patient's kind of in the center of all that, but we're just branches of that, and they're so involved and so knowledgeable, and that makes it it makes it easier in a way to be able to relay information to patients because they have such a strong background. And I think even those who don't, you have some patients that love to learn and read and do all of that, and others that don't want to do that background research, like just give me what I need to know.
Mhm.
Even those, I mean, there are so many groups now that patients are able to touch base and pick what they want to touch base on with each other about. The network is growing for sure, so it's nice to see that. I think both of your answers overlap each other.
Well, and in healthcare, just to speak to that, like the biggest goal that we have is we want to teach our patients how to be the best advocate for themselves, especially in rare diseases that not everyone deals with daily. And so when you come into a field like this and the patients are already such good advocates for themselves, it makes us be like, okay, how do I be even better? How do I help you be a better advocate when you're teaching me how to be a better advocate yourself? So it's a very intricate dynamic that you're right. We don't love this for small reasons. It's big reasons, and that's a huge one.
Yeah. Okay, so let's if anybody has any questions, feel free to unmute, turn your cameras on, or type into the chat box, whatever you feel comfortable with. But the floor is yours for anything. Nothing is off topic for these gals. I'll start with one. You both have experience in clinical trials, different experiences. Mysti, you have a PRRT experience as well, kind of getting Lutathera up and running and starting all of that. Where do you guys see things changing, or how you think the dynamic between the APPs, both in nuclear medicine and in medical oncology, is going to look once alpha is hopefully approved in the near future? Well, 2 years probably, but I can see that happening. So where do you guys see this going?
There's a lot of pieces. I think it will. I don't know that it will completely change everything, but it will add a lot of wonderful tools to that toolbox again, because we are still going to be using these other pieces, but it's going to give us another step in our process when there's not been answers, or when things are changing with a disease and we don't know which way to go next. This will be a better answer in a lot of cases. It'll give us a sooner answer for some patients, and that management will change because we're going to change the order of progression and order of operations, and that it's going to make things a lot more intricate because we're going to need more providers at that point to help manage the different ways we're doing things. We're going to have to really re-educate ourselves, and that's the biggest change, is learning how we do it, when we're doing it, and then making sure we can answer the questions and be available for our patients as much as possible.
I mean, the only thing that I would add to that is that, it's really exciting that we're gonna, potentially get a new treatment, like Mysti was saying, a new, tool in our toolbox, if you will. And I'm really encouraged by the data that's already come out that said, the overall response rate with, alpha is, better than, Lutathera. So, I mean, I'm really encouraged about that, and it's generally well tolerated. So that's a big win. So yeah, I'm really looking forward to, seeing more data and, putting more patients on trial.
Mm-hmm. I see things changing a little bit in clinic. I think with that volume, kind of like with when we started with Lutathera, I think we're probably going to see more like nuclear medicine APPs leading that clinic of patients. So I can see one other person being added to every team at least, or kind of structuring the clinic flow. So, patients can possibly expect to have more people on their team when that happens. So just getting used to, a different flow, maybe when you're on that treatment, things like that, just from a resource perspective, I can see that happening. What's one thing you're most excited for in the future, based on what you guys have seen?
I mean, I'm really looking forward to cabozantinib getting approved.
That will be
really looking forward, because right now, we have a few patients that are on cabozantinib off label, if you will. And so when that is, deemed as a potential next line therapy, because of the fact that it's off label, it can take, 1 to 2+ months for you to actually get the drug in your hand and to actually start it. So that's quite a hindrance at the moment. So for me, that's what I'm most excited about, for sure. So that way we can start, patients on therapy sooner.
Can you oh, go ahead, Mysti.
No, go ahead. Go ahead.
I was just going to piggyback off you said off label. Can you describe when we would make a decision to give a patient a drug off label and how that process goes for?
Yeah, sure. So, I mean, for example, I have a patient example. She had some liver dominant progression, but she had some other areas in her body that also had some growth as well. So we proceeded. She's gone through several lines at this point. She has, been diagnosed with this disease for over 10 years. And so we've exhausted a lot of therapies at this juncture. But we decided to, pursue liver-directed therapy, right, as we are pursuing cabozantinib at the same time, right? So cabozantinib was one of two options for her to pursue. And we thought in her case, it would be, best next line therapy because of the fact that we had such great results and data with the trial. So the decision was to pursue that off label because that would be in her best interest.
Okay. Mysti?
Well, piggybacking off of both of those answers, we are also having some patients that we're putting on it because the data is very promising so far, and the responses we're seeing are not just for one specific group of patients. So that is adding a tool to a lot of patients that we've not had the option, or we've only had these 4 options per se. To give an example, if you only have these options and you've been consistently working with those, having that next option or being able to use that option sooner to prevent more progression for a longer period of time is always something we're very excited about. But off-label, it can sound really scary, but it's really just, we know that it's working. We know what it can do. We just have not been able to get it fully approved for what we're using it for specifically. And that is why we're doing it off-label. If we think it's the next best thing for you and your treatment, that's where we're looking at the data we're trying to get it. But like Tiffany said, having that delay of being able to get it in your hands because it's off-label is the frustrating dilemma in our lovely world.
Mm-hmm. And I think something that patients confuse sometimes is off-label versus compassionate use. And compassionate use is when we do a specific protocol for one patient to give them a drug that's still in trials across the board. So it's not been approved for anything at that point. And that's why it has to be done as a compassionate use protocol. But off-label is this drug has already gone through trials and been FDA approved for another indication. So it's already on the market. There's already a process for that. There's already a way to order the drug in your pharmacy formulary and things like that. It's just that the code that we attach to it is not yet approved for it. And so that's the difference in the process. It's also why off-label use does not equal free drug. So compassionate use protocols are usually free drug protocols that are provided by a company. And then the off-label use, you could get lucky and your insurance copay will cover it and everything. Sometimes you do end up having a hefty bill or have to go through patient assistance or something like that. So I think your nurses would definitely be your point person for that process, and your pharmacists, but usually for the patient, the nurse.
Yeah, we get to do we can help with the prior auth, talking to the companies, appeals, peer-to-peers, things like that, trying to use it off-label. All the beautiful things.
Yes.
Any questions, guys? Again, feel free to unmute. Or anything anybody would like to add.
I just wanted to add just some advice for like any neuroendocrine patient. I would recommend if you're, whether you're a new patient or whether you're an established patient with your medical oncologist, I'd recommend, having the provider, because sometimes a lot of things are talked about, right, during your visit. Lab abnormalities are talked about, CT scans or MRI or PET dotatate or next line treatment. I mean, you've got a lot going on, right? And it's already probably been a busy day. Maybe you've had your labs, maybe you've had your MRI, you're tired, right? You're hungry. A lot of things are going on, right? So I recommend, having the provider maybe recap your visit, right? Just in like bullet form. It's, super quick. I like to do it with my patients. That way, we just have everything at the forefront that we discussed for that visit. It takes a little extra time, but in my opinion, I think it's worth it. Another thing I'd recommend is taking notes during your visit. If you're a note taker, highly recommend, 10 out of 10. Also, writing down and jotting down questions just like as you go. Like, so for example, like myself, I have like a little like grocery list like in my kitchen, and once in a while I'll write things down, right? And on my fridge, and it's always there. So maybe have something equivalent, maybe not on your fridge, but maybe, somewhere where you're, you frequent, right? So that way you can jot down, questions that you have, because I can't tell you how many times patients tell me, oh, Tiff, I had these questions, but I just can't remember them, and then unfortunately, sometimes they don't remember them. And then they will message me on the patient portal. And, I may not get to them that same day or the next day because I'm in clinic or something happened, or I'm out. So if you have those questions already pre-prepared for your visit, we can address them together. And then I think that was it. Yeah. Yep. That's it.
I love that.
I'm going to piggyback. I'm going to piggyback really quickly. So the other thing that I would recommend, I love that. I always tell people to write things down as you're coming, to bring a notepad with you, take some notes, but don't be afraid to ask the question, even if they're in the middle of explaining something. Ask it while you're thinking of it. We would rather you take the time to ask the question. I want you to interrupt me because I want to answer that question, because you'll forget it and I won't know what you wanted to know. So please interrupt us and take notes, write down questions, all of those things.
I remember my other one. Sorry, I remember my other one.
No, go ahead.
Clinical trials too. I feel like we may not bring it up as a provider because we know that you're not eligible for the ones that we have, right, at Moffitt. But, Mysti probably has clinical trials that, we don't have. And there's clinical trials throughout the US, internationally, right? So if you have a question, if you read something about clinical trials, I'd recommend that you bring it up during your visit. It's not that we're trying to hoard the clinical trials. It may be the fact that you at this point in your therapy or in your, journey, you may not be eligible.
Yeah.
But it doesn't hurt to ask.
Yeah, absolutely. I think my take home with you both is, and what I would want patients to kind of keep in mind is, your providers, especially your nurse practitioners, your PAs, and your nurses, I would argue, are those that are going to dedicate the most time in the clinic for you. They have the most, I'm not going to say they have the most time, but they have a structure for their days that affords them that they're there for you, and that's what their main job is to be able to help kind of bridge all of that you maybe are seeing elsewhere, and you can't, maybe you're too anxious to bring it up to your medical oncologist, and you don't know. I don't think there's ever a stupid question. I don't think a medical oncologist will ever think that either. But if that is a more approachable way for you, then bring it up to your nurse and your nurse practitioner, because they have ways. Most of them have been bedside. They know how to speak to a patient in a way that they break things down, I think, in a way that physicians maybe weren't trained on, or maybe just don't feel comfortable doing. And that resource should not be wasted, I think, when you have somebody like that on your team. And I think that's the main difference that I was kind of thinking.
I would agree. That's probably the way I end almost every visit and phone call I have with a patient is, I don't have a job if you don't ask me questions and call me. That's my main reason of being here. So keep me working. It's job security for me.
So I hope this session helped kind of everybody understand what the role of the nurses and your nurse practitioners or PAs are on your team. This will be recorded and posted online. And, for future webinars, if you guys have any questions that you guys would like these two ladies to answer in future webinars, please send them my way, and we'll be sure to bring them back for another. And we have whatever conversation you guys are looking for. These webinars are for you, and that's the goal with them. And thank you both so much for this conversation. I think I learned a lot, and I hope that this was helpful for everybody.
Thank you all. And thank you, Tiffany.
Yeah, thanks so much for hosting and having us. This was lovely and nice to meet you, so to speak, Mysti.
I'd love to. So Kim has a question. Let's hear it.
Oh, yeah.
Hi, this is Kim Mile, and I have my friend Jody with me today.
I'm a caregiver for my mother, who is an 88-year-old female here. She was diagnosed with NET approximately 5 years ago in the liver. At the time, we were told it was possibly fast growing, stage 3. She has been on I guess I'm not a nurse, so in my terms, she's been getting a chemo shot. And then it was switched over again. And it's now, I guess now back to, they say maybe stage 2, a little bit more slow going. So it has done very well for her, very little side effects for her. She has a lot of other health issues between pacemaker, diabetic, the list goes on. She's been having a lot of PET scans, pretty much we're having different issues, different things are lighting up. We are presently moved back to Fort Lauderdale, where we had been having our original diagnosis, and had another scan. My question is, I'm a little confused because they say there's some things maybe possibly lung, possibly other little spots are lighting up. How could I mean, I know I can obtain her scans, her discs and all that, to be able to speak to one of you all, for someone to review it. Maybe, have another appointment to see what I can do for her. She's great spirit. Her mind is great. Her body's just obviously at her age is kind of failing her a little bit. And obviously I've been taking care of her 6 years. I'd like to give her, to make sure I'm doing all the right things. She has on an excessive amount of pills daily, between, even over counter irons and different things for her deficiencies. So we're presently right now out of
Holy Cross.
Out of Holy Cross Hospital right now, where our doctor had left, went up to Orlando. We happened to move that way for a short time, so we continued to see him. Now he's back down here. So I'm a little bit, every time I go in for the thing, we just had 3 PET scans within probably a year, because she had some pains in her stomach again. Now they said something on the top of her liver. I'm completely confused. So I'm kind of like, I need I guess like a second.
She wants next steps. I think kind of like, what would you recommend that she do from here? She's a bit overwhelmed, I think. And it kind of goes back to I think what you said at the beginning, that you can still work with the community oncologist that she's been seeing, but this is really where a NET specialist can step in and help. And that's why I really thought it was important for her to join this call. So I'll be quiet and let the experts talk.
So I feel like, based on what you shared with us, that she would benefit from, a second opinion with a NET specialist, whether that be, with Mysti's team at the University of Miami or, at Moffitt. I'm not sure, Mysti, if you guys do telemedicine, but that may help. I don't know, specifics in regards to, what else she has going on. But if, travel is an issue or transportation, we do see new patients in this modality as well. So I don't know if that is available. But
travel is not an issue for us. Actually, my nephew had gone up to Moffitt, and they were absolutely fabulous with my nephew when he was 20-some years old.
Yeah,
so
getting treatment at in Deerfield, right?
No, that's our other friend Chris.
Oh, okay.
But so travel is not an issue. And when it comes to my mom, we actually just moved back from North Fort Myers, so I was closer to the hospital. She was comfortable with, in her mind, she wants to be. Healthcare over there is very hard to get right now. We were seeing doctors that were coming from filling in. The specialist in Lee County, it was making her uncomfortable, and I didn't feel I was doing my job good enough so we were traveling back and forth. I finally said, that's it, we're going to move back. So that is not an issue for us. I'd move the mountains to do what I can for her, to make sure that I'm comfortable with. If they're telling me they're seeing other things, but they won't treat it right now, or this is probably her best thing, I don't know. I guess in my mind, I would feel better for that.
Yeah.
So
yeah. And I think that makes sense too. Sometimes it's nice, like, you know, when one of my patients they want a second opinion, I think it's great to get, you know, a fresh set of eyes on her whole case. And especially if she's had, you know, that many PET scans within that interval, I think it'd be, you know, really wise of you guys to seek a second opinion with a net specialist.
And if Kim, I think the easiest way would be you have my contact information. You can start with just an email to me with where she'd prefer to be seen for her first, second opinion, if you will. Miami, Moffitt, or if you guys want us to coordinate with one of the other net specialists, we'll be happy to facilitate that. But feel free to just send me, all I need is a name, date of birth, and a phone number, and your permission to have one of our schedulers reach out and we'll just need like pathology report to start with. And then from there, we can get her scheduled for a second opinion. And after that, like Tiff said, we can, or Mysti could also do a virtual visit to start with. If you know, something else is going on and it's just not comfortable for her to come into the campus for the first visit, where we just kind of go over what's going on. Either way would be an option. So we'd be happy to help.
We really appreciate that. Thank you so much.
Thank you very much.
Welcome.
Of course. Well,
You guys are doing wonderful things. We appreciate all you do for the community. I certainly feel very fortunate to have both Moffitt and UM in my backyard.
We're lucky to have you guys. So thank you so much for joining, for asking questions, and I hope we get to touch base at every one of these and future in-person events as well.
Thank you for your time so much.
Thank you.
Thank you all.
All right.
Thank you.
Have a good night.
You too.